Greetings, everyone. Just can we get an indication if everybody can hear us clearly? If you can please send yes on the chat for us. We got a yes? Yeah. Thanks, Glenn. Okay, welcome to the NHLS, the National Health Laboratory Services, and the National Institute for Occupational Health. Just to give you a little background about the institutions, the NHLS provides a diagnostic service to 80% of the South African population. We have over 300 laboratories in all the provinces. And within the NHLS, we have two divisions, the National Institute for Occupational Health, NIOH for short, and the National Institute for Communicable Diseases, or the NICD, which many of you may be familiar with. They have been at the center, they have been leading the command center on the COVID outbreak. The NIOH is responsible for ensuring healthy, safe, and sustainable workplaces. And in terms of the COVID outbreak, we are conducting several training sessions that are occupation specific, ensuring that workplaces are prepared to dealing with the COVID outbreak. And what we have also done is put together a train-the-trainer session, which we're conducting today, and we may repeat the session in the coming weeks as well. But the idea is really to intensify our occupational health response. And so we are very thankful that you are able to join us today and to take the lead in terms of training or information sharing in your workplaces. So on behalf, my name is Tanusha Singh, and I'm leading the Occupational Health Outbreak Response Team at the NIOH. And I'm going to hand over to Ashraf Ratliff. He's going to be our program director, and he'll be telling you more of the objectives for today's session and introduce you to the speakers. Just to mention that during the course of the session, we will mute everyone. So you will, if you have any questions, please raise your questions as the presenters are presenting to you, and the presenters will pause at different periods to address your specific questions, just to ensure that you are understanding and you are clear on all the slides that have been presented to you. Over to you, Ashraf.
Thank you very much. And that's my colleague, Dr. Tanusha Singh, who is the head of the NIH Immunology and Microbiology section here at the National Institute for Occupational Health. She's also the head of the NIH's COVID-19 Outbreak Response Team, which this team is responsible under her lead for all of the communications and information and training sessions that we're undertaking. Today's training, as we've emphasized, is a train-the-trainer. It's an attempt to not just provide information and resources to people, but it's also an attempt to try and replicate and multiply the number of people who can share information out there. So that's the main reason why we invited all of you who are online and those who are here at our Braamfontein campus in the Tony Davies venue. We hope that at your workplaces you have rooms like the one we are now, where there's definitely less than 100 people, and you have group video links to this. As you know, our microphones on your side is muted. For large numbers, it will be unmanageable to have your microphones on as well. And therefore, you need to ask the person who's manning your keyboard on the laptop or PC that is linked to the Zoom video link to type out your questions. If you could just organize yourselves for somebody to type and somebody to collect your questions in order for us to receive all your questions. At the bottom of your screen is the bar. If you move your mouse cursor down to the bottom, you'll see a chat bubble. That chat bubble is where immediately we're going to ask you to click and add all your email addresses if you require us to make available to you some of the standard operating procedures, for example, issued by the National Department of Health, the guideline circulars issued by the DPSA and the Department of Basic Education. Unfortunately, I can't flip it on the screen for you now, but we are going to work on that technology to ensure that we can show you what we're talking about. So please go down to the chat bubble, click in there, and it's a form of a register for us. If you want these documents to be circulated, including the PowerPoint slides that in PDF format, we need your email addresses at the bottom. Click the chat bubble, type in your email address and your name and your organization, and we will be able to be positioned to supply those documents. Soon we'll be able to do that live. So coming to our program for today, this is the National Institute for Occupational Health, the NIOH's COVID-19 Train the Trainer Workplace Preparedness and Prevention session today from 10 until 1. We've had an introduction and welcome from Dr. Tanusha Singh. Our next contributor is going to be Dr. Odette Volmink. She's going to again give us the latest update on COVID-19. What is it and where are we? And also address the whole question of workplace preparedness and prevention. I welcome Dr. Odette Volmink.
Good morning, everybody, and thank you so much for joining us. To all of you there who are at the front line, I know that everybody who is joining in realizes the importance of all hands on deck, particularly healthcare professionals in every setting in tackling this coronavirus. And even as the Department of Health and you know, is tackling issues of patients and looking after the health of our workplaces, you know, at the National Institute for Occupational Health, we've seen that so many questions are coming in around workers because it's going to affect a lot of our workers. And so we do need to be prepared, and this is just a train-the-trainer event, like Ashraf said, to try to prepare us for tackling COVID-19 in our workplaces so that not only we feel safe, but also the employees that we service feel safe. Sorry, let me just try to get this mouse to work. Sorry, Claire. Yeah. I'm so sorry, we're just experiencing a few technical issues. We're hoping to be on track shortly.
Can I just for a moment join Dr. Volmink, Odette? It's an important thing just to announce to you now that the NIOH, from an occupational health and safety point of view, is responsible for assisting and supporting around COVID-19 workplace preparedness and prevention. We will flash this up again in a moment, but the hotline for occupational health COVID-19 workplace support is 0800 11 1132. 0800 11 1132. Thank you.
Thank you. So now this is quite a rapidly evolving topic, and we are learning as we go about. And because you as chiefs in occupational health in your respective sectors, there's an onus on us to keep informed of this constantly update ourselves. So here are some of the websites that please visit frequently just to see if there's any updates on what's happening with this pandemic, and is there anything new that's coming out in terms of guidance to see what we can do in workplaces. Okay, so by way of background, this all seemed to come to a head on the 31st of December when the WHO in China had noticed a cluster of pneumonia cases in Wuhan. And by the 7th of January 2020, the causative agent for this pneumonia was isolated, and it was identified as a new coronavirus. And this coronavirus is now being called SARS coronavirus 2. That's SARS-CoV-2. And then by the 30th of January 2020, the WHO had now declared a public health emergency of international concern. And on the 5th of March, tragically, South Africa then had the first case of COVID that was confirmed. By the 11th of March, the WHO had declared a pandemic with COVID-19 disease. And on Sunday, the 16th of March, our president declared a state of disaster and put certain things in place. Okay, so this is constantly changing, but as we can see in this map that it affects, most of the world is affected. There's so many countries, there's so many global cases, more than 150,000 global cases, and over 5,000 deaths have been confirmed.
Oh, just check on. Just check.
Hi, can everybody hear me? We've gotten something to say that our participants are struggling with the audio on this field. Can everybody hear? If you can, please put a yes in the chat. And if you can't, please put a no, so that we know whether or not you can sing.
That person muted himself. Yes.
Okay. Okay, so I think that we've got some yeses, so we're going to continue.
So I'm not sure if I'm in screen. Yes, I think I am. So if we can just tilt that slightly up, Glenn, thank you. So the key thing here is that the Zoom platform is new to most of us. Under the circumstances, we're using technology that we might not have used on a daily basis. So we're learning as we're going in, and that's necessary in any situation of a declaration of a national state of disaster. Can those who are not be able to hear us, please just check your software if you've not muted your audio on your side, either in the audio function on the actual laptop or PC or in the actual software. People have indicated to us that they can receive both video feed as well as audio feed. Thank you very much. Apologies for that technical interruption, Odette. Please proceed. Thanks.
Okay, so we know there's global spread. We know that this is a serious condition because more than 150,000 people have confirmed cases and more than 5,000 deaths, and it is growing. Okay, so within South Africa, like I said, there was an announcement on the 5th of March that we had our first case. As of this morning, there are 85 confirmed cases with not only a history of traveling to parts of the world that have transmission of COVID-19, but there's also now noticed that there's local transmission in our communities with COVID-19. Okay. Now, just by way of taking it down to the microbiology of this organism, coronaviruses are single-stranded, enveloped, positive sense RNA viruses. This is just for your information, and there's a little picture on the slide. And this virus is covered by glycoproteins, which are the red things that are on the picture. And because of this, it has a crown or a halo. It looks like that. And so the name corona is Latin for crown, and that's where the name comes from. But the important thing to know in this slide is that coronaviruses are responsible and have always been around and have caused self-limiting upper respiratory tract infections. However, there have been new coronaviruses that have come out, which we'll speak about. The first one is the SARS. In 2002, 2003, we had that global outbreak where there was a new coronavirus that was then identified as the SARS coronavirus. And it had spread to 37 countries within 2 weeks of the original outbreak reporting. And there were about over 8,000 cases and more than 700 deaths from that virus. Then we had later on in 2012, a new coronavirus came out again, and this was the MERS coronavirus. And there were more than 2,400 lab-confirmed cases with more than 850 deaths, mostly around the Middle Eastern region, but also in 17 other countries. And it seems that coronaviruses are common to humans, but also to animals. And when transmission has crossed over from animals and then into humans, our human immune system has not tackled that type of coronavirus, and so often cannot respond quickly enough, and so there's an outbreak, and this seems to be the mechanism of contraction in the beginning. With the SARS, the initial SARS coronavirus, the animal vector was bats, and then in MERS there was the animal vector was also included, the camels. In this current SARS coronavirus 2 that started in Wuhan, there's a lot of speculation, a lot of studies have been done, but not yet confirmed what is the source, the original source of the virus. So now, how is this spread? Sorry, Glenn, can I ask you just to move that box a little bit? How is this spread? Please forgive me, I'm just struggling to see my slides. COVID is spread by droplet spread, okay? So oftentimes when somebody is mostly infectious is when they're coughing and they're sneezing, and the droplets that come out, even when we're talking, but particularly more so when we're coughing and sneezing, then projects 1 to 2 meters, and it produces these droplets in the air. And these droplets also can fall down and contaminate the surfaces around. And surfaces not only 1 to 2 meters, but can even extend a little bit further. So when an individual comes and is in that breathing zone of 1 to 2 meters, they can inhale these particles, which then would attach and cause disease, or if they're touching surfaces where coronavirus has contaminated those surfaces, and then they touch the areas of their face, their nose, their mouth, they would then breathe in these droplets and would cause infection. Okay, so it's estimated that the incubation period is between 2 to 14 days. Just a little bit more on the transmission and the spread. So it's spread by direct contact. You're either touching an ill person or you're touching contaminated surfaces, as well as inhaling the droplets. Okay, we are most infectious during sneezing and coughing, so during the symptomatic phase of the disease, when you are sick. The virus is replicating quite a bit, and so a lot of virus is spreading. And the larger droplets kind of fall to surfaces. Okay, so a little bit more on the virus itself. It's got a fragile outer membrane, as we saw that picture in the beginning. And here's a sort of electron microscope picture of an iPhone with a lot of coronavirus around it. But it's got a fragile membrane, outer membrane. And it is less stable in the environment and can be killed by simple disinfectants. Okay? There's no evidence at present on the survival of the coronavirus in water and in sewage, but it's thought that it doesn't survive for too long. But it's not certain, however, how long it survives on surfaces, and studies into this have been ongoing, and some of the results show that it can survive from 12 hours up until some studies show that it can be present on the surface 6 days after someone who is infected is in that area. So the survival time of the virus in the environment depends on many factors. Some of the factors are the pH of that environment, the inoculum size, that's how much of the virus is concentrated in these droplets, the level of dryness of the environment, the temperature, the exposure to disinfectants, and the type of surface that it settles on. So it's important to note that common disinfectants, common ones, such as 70% ethanol and bleach, can kill this virus. Okay. So we're just going on to talk a little bit about the symptoms. Right. So the case definition that has been defined by the NICD is that people under investigation, these are suspicious cases that we need to test, will show features of an acute respiratory illness with a sudden onset of one of the following symptoms. And these symptoms can include a cough, a sore throat, shortness of breath, or a fever, or of measured fever of over 38, or a history of a fever. But the case definition remains the same, that also on top of these symptoms, there needs to be a 14-day prior to the onset of the symptoms in this patient, they were in close contact with a confirmed or probable case of COVID-19. Or they would have had traveled to these areas where there's ongoing community transmission of COVID-19, or they are a healthcare worker or a worker working in a healthcare facility that is now currently treating patients with COVID-19 disease, or in the case where there is a severe pneumonia of unknown etiology. These are suspected cases, and these would be persons under investigation. Okay. So 80% of people, of the cases that have been seen and documented of COVID-19 disease, 80% of these cases have mild to moderate disease, common flu-like symptoms. So we said high fever, shortness of breath, can be severe respiratory distress, sore throat, headaches, cough are the common symptoms. Of these cases, 15% of the cases require a hospital admission to deal with these symptoms. And then 5% of the cases become very critically ill, that they require ICU admission. And of these cases, 2% of people would die. And the outcome is worse so in people who have underlying pre-morbid conditions such as pulmonary disease and also in the elderly.
Can I pause you there for a moment?
Sorry, I'm just being paused.
Just to support the process that Dr. Walming Odette is taking us through, could we encourage you to use that bubble at the bottom of the chat to start asking any questions you might have? And we have had guidance from the team that's supporting us here today to say that if there's any urgent questions that relates to a particular slide that may just be dealt with, we might pause to want to deal with that question, given the nature of the trainer event today. So please, down at the bottom, the chat bubble, where you've typed in your email address, for those who've not yet typed in your email address for us to have a register of the attendance. For those who are in rooms, they need to do an attendance register for us in the rooms and email it to us at info@nioh.ac.za, where you are gathered in other provinces or outside of the Johannesburg and Braamfontein area. But for now, down in the chat bubble section, please type any questions you have that may be related to a slide, and please indicate the heading of the slide if you want us to speak to a specific slide. Thank you very much, Odette.
No problem. Okay, so we just now spoke about the symptoms, and we just now spoke about the case definition. But now we said people who fulfill that case definition, right? Just to go back a little bit, that's those people who present with acute respiratory symptoms of a sore throat, a cough, shortness of breath, and fever, and who were also in contact with a confirmed case, or a suspected case, who had a travel history, or for workers in a healthcare facility, be them security guards, be them doctors, nurses, people who are taking care, also reception staff, if they are working in a facility where a COVID patient was treated, or a patient with COVID-19 was treated, also in the cases of severe pneumonia of unknown etiology. These people would be persons under investigation. So currently, only persons under investigation are being tested, and initially all cases needed to be discussed with the NICD doctor on call before samples were collected. However, now it is important, to call this toll-free number from any healthcare workers who have queries of whether or not they should test. There's it on the screen. It's 0800 02 9999. Okay? So these are the people who would then be tested for evidence of the coronavirus. Okay. So this is, I think, is an important slide, and also maybe a slide that you need to make and you need to adapt for your own workplace. Should people call in to tell you, or should the employees around you be worried about whether or not that they have COVID-19? So the first thing, as always, is to stay calm. And then we need to look at, do you meet the criteria? Do you have cough, temperature, shortness of breath, all those kind of, do you fulfill the symptoms, right? If yes, you fulfill the symptoms, then tell us about a travel history. Have you been traveling? Or including there is, have you been in contact with someone who is diagnosed or suspected? Or are you a care worker? And if you meet those criteria, then you need, the advice should be that you should stay at home and contact the NICD, right, to see whether or not and where you can be tested. And it's on that number, okay? If you don't have the symptoms, you should go to your doctor and see exactly what is wrong with you. I'm sorry, I can't put but if there's a no to your symptoms, then you need to go and see your healthcare provider. If you have all these symptoms, the cough, high temperature, all these symptoms that we know, but you don't have a travel history, you haven't been in contact with somebody who is, has COVID disease, or if you haven't also been a healthcare worker in the setting where you've been treating, or patients with this have been treating, then, or if you haven't been a close contact, then you need to consult your doctor. Okay, then it's unlikely and you should consult your doctor. Okay, so if testing is indicated, like we said, you meet those criteria that we spoke about. This patient needs to be isolated as soon as possible, right? A specimen needs to be collected, and immediately you need to start talking to the person about tracing the contacts of that person. Okay, so those kind of are the three main steps. So when we're talking about contact tracing, who is a contact? A contact has been defined as any person who is in close contact with a confirmed case, either while the confirmed case was ill and presenting with symptoms, or even 7 days prior to the person developing symptoms, okay? And so the contact is someone who's had close contact, just looking at this picture here. Hi Glenn, can you just show up this picture here? Who's been around a confirmed case within 2 meters, so that's oftentimes within the workplace, people who work together, also within the family setting and the home environment, those also become contacts. And then the healthcare worker or the person providing care. If that person who is providing care is not wearing the recommended PPE, they then are also at risk, at high risk, and are a contact. Okay? In the case of travel, which hopefully we won't have too much of now, but even in the past, if somebody is sitting a row of 2 from the front, from the back, from the side, they are also a contact. So if that confirmed case was traveling in an airplane and 2 in front of him, 2 to the side of him, so 1 and 2 to the side, 1 and 2 to the front, 1 and 2 seats to the back, that is a contact, and these contacts need to be traced. So what happens with these contacts? These contacts need to be monitored, and they should be advised to self-quarantine at home for a period of 14 days after they were exposed to that known case. While they are self-quarantined, they need to take their temperature once or twice a day, and they need to look out for symptoms. They need to look out if they become symptomatic. They need to call their health worker, they need to call the hotline and try to get help and be tested. These people, it's not a time off work where they relax and they can go and watch movies. They need to quarantine and not have any unnecessary contact. They shouldn't travel, and they also should remain reachable for monitoring, because these cases are being monitored by the NICD. So this is a slide that is taken straight from the NICD website on how to do the contact tracing and monitoring of the close contacts. So once the case is confirmed, we've tested, someone presents with symptoms and they meet the case definition, we test and we confirm the case. We've already identified the contacts. A contact list needs to be drawn up. There is a contact list in the NICD website that needs to be drawn up, and this, the provincial CDCC identifies, completes the list. Every contact, all their contact information needs to be put on that list. Completed contacts are emailed to the NICD. These people will be asked, like I said, to self-quarantine and then to monitor daily temperature checks, daily symptom monitoring, and this is then reported to the NICD. And there's an NICD delegated, a CDC delegated person that will contact these people telephonically to check, to monitor them if they have symptoms so that they can respond to them. That's currently what's in place at NICD. Now, we've been speaking a lot about self-quarantining. What exactly does that mean? So to quarantine means to separate a person that's not yet symptomatic but has been exposed to this virus. To separate them from people who are not exposed, okay? So this person isn't really sick, but they could potentially be sick, and so need to limit the exposure to other people so that to prevent the spread of disease. So it can be effective in limiting and slowing the introduction of this new pathogen into the community around us. Quarantine, as we've seen in the news, it can take place in home or it can take place in a designated facility. And this oftentimes depends on the level of risk and the intensity of the exposure, depending which level of quarantine needs to be employed. Like we've seen from all the people who were expatriated from Wuhan, there's a voluntary quarantine facility that they have been placed in for 14 days. A household member of a confirmed case will probably stay in their home for 14 days. A healthcare worker who has not worn the appropriate PPE when having contact with a confirmed case, this healthcare worker, the guidance is this healthcare worker would be allowed to work, but would be requested to self-quarantine if they develop symptoms. So these healthcare workers need to be rigorously monitored so that in the presence of symptoms, they can be quickly isolated and treated so as to not affect our healthcare system that is already overburdened. With regards to the treatment, okay, we know there's currently no specific treatment to treat SARS coronavirus 2 or COVID disease. So what has been recommended on the WHO site, on the NICD guidance document, is that it's all about supportive therapy and monitoring these patients. So where needed, if the support is oxygen, to treat the respiratory distress, if it's shock, to give fluids where it's indicated, to give empirical antibiotics where it's indicated. Some of the literature also says that we need to be slow to give systemic steroids because people are not responding well, okay? These patients, like I said, need to be closely monitored by the healthcare practitioner who is looking after them. These practitioners know that they need to assess the comorbid conditions and also treat those comorbid conditions to improve the prognosis of the patient. Communication with healthcare workers is essential with their patients and their family to provide support to prevent panic. Contact tracing is also the responsibility of the healthcare worker to identify the contacts. And there's some evidence, early evidence that antivirals can be used, but these studies are ongoing. For the purpose of this training, we've given some indications of the treatment options, but our focus is more on workplace interventions. So if you need any more information, there's the NICD hotline, there's the NICD guidance document, and then there is the WHO website to get more information if you need to clinically treat these people. Okay. It's also important to note that currently there are no vaccines available yet for COVID-19 disease. But we have been advised, it is advisable to take the flu vaccine because the influenza as well as COVID, they present very similarly. So we also need to try to get the flu under control for the season so that we're not testing unnecessary and we have a lot of flu cases. So we have been advised to take the flu vaccine to prevent influenza, not COVID-19, to prevent influenza so that unnecessary testing does not need to be done for COVID-19. And also your immune system is not so compromised should you have COVID-19. Okay. So shall we stop there before we take questions? This is kind of about the disease. If there are any questions, and then we maybe can move on to workplace treatment.
Yes, we do have some questions, Odette. And before I proceed with the questions, I'm wondering if some people are not clicking the wrong Zoom video link for this afternoon session, which is not being broadcasted at this point in time. So I'm wanting maybe on that other chat, which we've been receiving WhatsApp pics from, for somebody on that chat, I'm not sure if it's a colleague of ours in the SHE department, to ask those people which link they clicked, because there's a 10 a.m. link and there's a 2 p.m. link. I am of the view that the people who are now saying they're not receiving audio or video link is on the afternoon link. And so we are going to flash on the screen the link for you which will be typed in the chat to share with other colleagues, and for one of our colleagues to go onto this afternoon's link and to type in that chat group there this link for this video. We need to move beyond the technical glitches that is being experienced to the questions that you've shared with us. So one of the first questions that we've shared, that we've had from Dion Swanepoel was, you mentioned 70% ethanol disinfects. What is the lowest percentage you'd recommend? I've heard people use 60. Your thoughts? I'm not sure if somebody wants to join us as well.
I don't know if maybe we should leave this section. We are going to have a cleaning and disinfection
right. Moving on to the next question.
Somebody's going to speak specifically to this. So maybe we can...
Osman's question as well. In Osman, 1% hydrogen peroxide, we'll leave that with regard to mouthwash. What further precautionary measures should be taken, either the individual or the advisory department, after the recovery of the individual who previously tested positive for COVID-19, especially having known that there is no cure at the present moment? Can we cover that now? In short, what are the long-term precautionary measures that should be taken?
Okay, and this is someone who's already been infected?
Well, we can ask the person. Let's assume that we have two scenarios or more than one. Could you answer that?
Sure. Sorry, let me just read it. Further precautionary measures should be taken by either the individual or the advisory department after the recovery of the individual who was previously tested positive. So if you've previously been tested positive, there's an immunity that you get, you know. Sorry, I'm looking the wrong way. There's an immunity that you get to the disease. So if you recover from the disease, that's great. You have then developed an immunity to it. So in those cases, you know, you've developed the antibodies, and so precautions post the fact may not be necessary, depending on how you recover, you know. Some people, we don't know yet, but some people, due to the fact that 5%, I think it was, will have prolonged ICU admissions. With that comes a lot of impairments from being in ICU for a long time. So those would be specific to that patient. They may need to have additional treatments to get their respiratory rehabilitation, to get their respiratory system functioning again. And so I think that's as much as I can say. There's no precaution measures that I can think of after the fact.
Then there's the question from Osman. SADA, and I would assume this is a South African Dental Association position, is to advise dental practitioners to perform proper history and increase infection control measures, and also postpone elective procedures and limit treatment to emergency procedures only. Please advise on these recommendations.
I think these are good recommendations, you know, and I think that we're going to talk a little bit later about doing a risk assessment. So it's important for, you know, each practitioner really to do a risk assessment, not only the risk of the patient coming into our practice, but also what facilities we have in place in the practice in terms of ventilation and things like that. And so to make recommendations based on the specific risks. But where I think it is important to take a good history from the person, have effective infection control measures, and maybe if the control measures, other additional controls that can be put in place, engineering controls, SOPs around safe practice, also good hygiene, all those are still not enough to mitigate the risk for that dental practitioner. Then they, you know, should also only be advised to do emergency procedures or where needed.
And Odette, I can imagine that perhaps in the very same workplace, there might be those people dealing with customers who, in a risk assessment, might have a different risk profile, than somebody might be working in the support services in the back, not dealing directly with customers. Absolutely. In different settings.
Absolutely. So just to reiterate that it is very specific on, you know, what recommendations are made to the setting and to that individual worker.
Thank you. So the next question from Dion Swanepoel is there a way of testing surfaces for COVID-19? For argument's sake, can the hotel in Polokwane be tested afterwards to qualitatively prove that it's free of COVID-19?
I don't know if I can maybe give this question to Tanusha. Sorry, Tanusha.
Could I ask? There's a question from Dion. Is there a way of testing surfaces? I'm going to check if we're all in the. Yeah, I think we all are. So, is there a way of testing surfaces for COVID-19, for argument's sake? Can the hotel in Polokwane use, I think, for the Chinese people, or the people, South Africans returned from China by the government, in Polokwane be tested afterwards to qualitatively prove that it's free of COVID-19?
So there are tests that can be done to test the environment. The only challenge with that at the moment is that there is a PCR test, and it does not differentiate whether the particle is viable or non-viable. So although you're going to pick up the RNA material, it may not be viable, and so you're going to get that the particle, you have detected it, so it's positive, but it may be dead already. So that's the one thing. The other thing with testing the environment is that there is a shortage of tests currently. From the clinical point of view, we need these tests to be able to detect people and treat people. So the best thing from an environmental point of view is to clean the surfaces rather.
Okay, and we will be having a session by one of our colleagues dealing exactly with that. The next question, I think, is from Lizelle J. What other alternatives can be used since alcohol sanitizers are out of stock?
I think we should cover that when we're doing
Yes.
cleaning and disinfecting.
Excellent. Okay, so, and then, well, that was me asking everybody if you can have the video feed and the audio feed. Please indicate the do's and don'ts whilst in self-isolation. For example, can I go to the shop? Can I watch TV with the family, etc.?
That's a tricky one. And it seems like a common question, because the thing is we're going to try to, as much as we can, within our families, when we self-quarantining, to limit that distance between family members. But also, we must realize that it falls onto surfaces. So how far away from someone is it safe? It's tricky. It needs to, there needs to be proper cleaning practices that go into it. So sometimes it's actually better to self-quarantine the person within their room, for the safest way, and limit that kind of contact. But it does become very tricky to practically do this within the family unit.
Okay, so the next question is, how can people test their temperature every day if they don't have a thermometer? Does the NICD issue thermometers?
For people who are undergoing contact tracing, they have been issuing thermometers.
Will the NIH and the NHLS release formal guidance regarding routine diagnostic testing in our setting? And I assume our setting is healthcare setting.
There is a guidance document. It has already been released between the NICD and the Department of Health. So the guidance for who to treat or who to test is all on this. At the end of my presentation, the last slide will be useful resources, and the link to the guidance document is there. Please also have a look. There's many other links on the NICD website that speaks specifically to COVID. There's lots of technical manuals that are available there, particularly for the treatment, diagnosis, treatment, contact tracing of people.
So what is the appropriate PPE for occupational health practitioners who may be the first point of contact for an employee who meets the case definition?
I think that you will cover that when we speak to the next part, which is what to do in our workplaces and how to get prepared.
Okay, so then what is the appropriate PPE to wear in the lab?
I think we'll cover that
as well. And is it the person about correct jig solution linked to the Dion question? Is there sort of the do-it-yourself version of preparing the sanitizers? My sense is my colleague Monica we'll deal with that once we get to that presentation. I think we'll pause on the questions now, and I'll check up on other questions, people. So a reminder, for you who have joined us now, who've clicked on this afternoon's link and was sent this morning's link, and now have audio and video, please add your email address to the chat bubble at the bottom of the bar of the Zoom screen, and add your email address there. We're also inviting you to add your question that you have, including questions specifically on the current presentation. I'm handing back to my colleague, Dr. Odette Volming, who's going to proceed now with the question, I think, of vaccinations.
Now we're going to go on to work.
Thank you, Odette.
Thanks very much. So far we've spoken a little bit about what kind of the knowledge is out there about the COVID disease and where to find, where it's been limited in the slides, where to find additional information about treatments and things like that. Okay. So now within a workplace, so we know the hospitals are going to tackle this, right? Please forgive me, I send my apologies for my colleague, Dr. Mpumi Ndaba, who was going to do this part of the presentation, but she's been called to work on COVID disease in another place. So we're now going to be talking about the workplace. We know that there's going to, the Department of Health, our healthcare workers out there in hospitals, in clinics, in all these GPs, in practices, in all these healthcare facilities are going to be tackling it with the patients. But there are many other members of the community who come to our workplaces. And programs, systems need to be put in place. And as the professionals within these systems, that is one of the reasons that we're doing the train the trainer, so that within your workplaces, you put the necessary systems in place to prevent the spread within your workplace and to protect your employees. So firstly, let's look at what are the potential sources of exposure to COVID-19 in the workplace. So it can come from the outside, our clients, and whatever things we do, even contractors coming in, or within the workplace. It can be within our staff that are passing it on from person to person. So it can be community acquired, or within the processes and how we work within the workplace, we can spread it to each other. So it also can be workplace acquired. So workers are definitely at risk of infection, and every person in our country has a possible risk of exposure to COVID-19. But there are certain workers, particularly those who are interacting with people, that may potentially be exposed, that are at higher risk. Okay? We also need to look at the staff that we have, and if they are at risk of getting poorer outcomes from COVID infection. And these would be workers with pre-existing conditions such as asthma, diabetes, heart disease, cardiovascular disease, cancers, any kind of immune compromise would fare worsely if they did contract this disease. So those are the workers at risk. And so in terms of high exposure risk group workers, this list is by no means exhaustive, okay? But the people who would be possibly more in contact with a client who has COVID-19 infection would be airline operators. And these now include all staff, from cabin crews, the cabin crew, the pilot, the cleaners, the mechanics, also border control, security officials, border control officials, healthcare workers are a big risk group. And as we've seen from tackling Ebola and other outbreak conditions, they are often at the front end and often contract the disease. So we really need to look after our healthcare workers because also of the burden that it places when they are out of work on the healthcare system. And these include EMS workers, doctors, nurses, medical staff, but also we need to remember the security staff, the reception staff, the cleaners, all categories of workers in healthcare facilities. I know a few of you asked seem to be from laboratory services, and laboratory services are also a high-risk group, which include all the medical technologists, scientists, laboratory aides, the researchers, the clerks, the cleaners. Pathology and funeral services are also a high-risk group, as well as the people who do waste management, like pick-it-up workers, water treatment plant workers, carers in different care facilities, old age homes, those kinds of things, and also teachers who are dealing with learners who come from areas of the community and may be infected as well. So these are, like I said, by no means exhaustive, but these are some of the people who are at high risk. Okay, and in the high risk groups, we mustn't forget the support staff. You know, we mustn't forget the cleaners, the security workers, the transport people, the canteen staff, tuck shop workers, maintenance staff, the visitors, all these people. We need to look at them in our risk assessment when we're looking at the risk of our workplace and trying to put in mitigating factors to try to control that risk for our employees. Okay. Now, we're often guided by the legislation. In occupational health, we have the Basic Conditions of Employment Act, and this is to give, to ensure that fair labor practices are in place. With regards to occupational health and safety in the workplace, we have in non-mining sector, we have the Occupational Health and Safety Act that governs all workplaces in non-mining. And this basically looks at the health and safety of persons at work and tries to ensure that the employer does not impose hazards on the workers. The employer creates a safe working environment for workers. And this is a legislation that we are all bound to. Within the mining sector, there's the Mine Health and Safety Act that ensures healthy and safe environments in mines and quarries. And then these two legislations, the Occupational Health and Safety Act and the Mine Health and Safety Act, are they look to provide a good, safe workplace, and they also give details where there is a hazard in the workplace that things need to be done to mitigate the hazards in the workplace, and they try to give guidance on that as well. Where those mitigations fail and somebody acquires a disease from the workplace, there are also legislations that then kick in, and we have the Compensation for Occupational Injuries and Diseases Act that provides for medical cover as well as compensation for either occupational injuries or diseases in the workplace. And these are injuries and or diseases that are not covered by the other act, which is the Occupational Diseases in Mines and Works Act, otherwise known as ODIMWA. And this caters for the mining industry in mines and quarries, where occupational lung diseases or cardiorespiratory diseases are catered for in that act. So we do have legislation that says that we need to protect our workers. We need to provide a safe working environment for our staff. Now, this is just a little bit more about the acts themselves. We spoke to the Occupational Health and Safety Act, and broadly it requires that we provide a safe workplace, but underneath there are regulations that speak to the Occupational Health and Safety Act. And particularly in the setting of COVID-19 infection, with the regulations that would apply would be the hazardous biological agents regulations, okay, which say what to do in the case of an infective agent coming into the workplace, what steps can be taken to mitigate these. So in the hazardous biological agents regulations, it divides the hazardous biological agents into 4 groups, okay? Group 1 is hazardous biological agents that's unlikely to cause disease, okay? Like a flu, just the common cold is not really likely to cause disease. So there's not too much that needs to be done around this. Then we have group 2 agents. These are biological agents, that means bacteria, viruses, fungi, any kind of biological agents that may cause harm, cause human disease, and can be hazardous if a person is exposed to, but it's unlikely to spread into the community. And also there's effective prophylaxis or treatment available. So should you be exposed to this agent and acquire this disease, it is treated quickly and effectively, okay? Then we have group 3 agents, group 3 biological agents that may cause severe human disease. And it presents a serious hazard to the exposed person. Also, one of the features, it may present a risk of spreading into the community, but there's effective prophylaxis and or treatments available. So let's think about a situation like TB. TB is a common situation in our communities and in the South African setting. It may cause severe human disease, definitely. It presents a serious hazard to the exposed person and there's a risk of spreading to the community within the workplace, but also to the community. And there are anti-TB drugs that can be taken 6 months, and there is possibility to cure. There's treatment available. So that's a group 3 type biological agent. Now we look at a group 4 biological agents, and these are the ones that cause severe human disease. It's a serious hazard if people are exposed to it, and it may present with a high risk of spread to the community, and there's no effective prophylaxis or treatment available. So, there was a lot of discussion. Does COVID-19 fall in group 3 or group 4 was the question. But there was also some, when the regulations speak to the classification of biological agents, we do know that COVID-19 can cause in 15% severe human disease. There's a risk of spreading. We know how easily transmissible it is. And currently we don't have effective prophylaxis or treatment. So it could be a type for group 4 biological agent. And so also they say that if in doubt as to which of the 2 alternatives, if it's group 2 or group 3, is most appropriate, the biological agent shall be assigned to the higher of the 2. So right now we're looking at as if this COVID-19 disease is more a group 4 agent. Okay, so there's certain things that need to be put in place. Okay, so what needs to be put in place? According to the HBA regulations, that's the Hazardous Biological Agents regulations. There needs to be information and training to staff. There are certain duties of the person who may be exposed. A risk assessment needs to be done in the workplace. Monitoring of the exposure needs to be done in the workplace where possible. Medical surveillance needs to be done where possible and where the risk assessment dictates. Medical records or records of hygiene assessments, records need to be kept. And controls need to be put into place to prevent exposure to hazardous biological agents in the workplace. And if necessary, PPE needs to be done. Okay, so that is what is legislated by law according to the hazardous biological agents regulations. So then, in order for us to try to fulfill what needs to be done by law, there are some minimum expectations that are required from the employer. Because in order for us to tackle this complex outbreak, particularly in the workplace, we need buy-in. We need buy-in from management, we need buy-in from employees and their representatives, we need buy-in from government. We need top management commitment to provide a safe and healthy workplace. And some of those things talk to having an effective occupational health and safety policy in the workplace. We need to do our risk management matrix. We need to have all our other support systems on board, be it finance, be it HR. We need to have a business contingency plan within the workplace. So these are things that need to be addressed in individual workplaces. And we need to have a functioning health and safety system. And, you know, most people do, but where there has not been a functioning health and safety system, now is the time to be compliant, to get on board, and to have an occupational health and safety system for workers in the workplace. And some of the minimum requirements mean that there needs to be a health and safety strategic committee, there needs to be policies, standard operating practices in place. It's also a big component of the human resource department. There needs to be health and safety reps as legislated in this Occupational Health and Safety Act. There needs to be health and safety committees that meet as legislated in the Occupational Health and Safety Act, and management, staff all need to be on board. And there are certain things that need to be done in the workplace, like risk assessments. Where there are incidents, there needs to be an effective incident management program that allows for adequate follow-up to prevent the incident again. And there needs to be a cycle of continuous improvement in the workplace. And there also needs to be an occupational health and safety training program. Okay? Other support structures need to be in place with relevant HR policies. People who are traveling, there needs to be a clear travel policy within individual workplaces, clear conditions of employment with regards to sick leave, IOD leave, what are the leaves when people are under self-quarantine. Companies need to decide what their HR practices will be in order for us to isolate people when the need is there to prevent spread, not only in the community, but also within our workplace. We needed wellness and employee assistance programs need to be in place for workers. Okay. So we said one of the things would be one of even the legislated things, just to go back to the HVA regulations. We have a duty to information and training, to provide information and training to our employees. So sorry, just going back. With regards to education and information and risk communication. Within workplaces, depending on how the process of this work and how work is managed, we need to set up communication platforms that need to be accessible to all workers, be it security staff, be it cleaning staff, be it office workers, be it our clerks, all workers need to have access to this. And credible, relevant information around COVID-19 needs to be presented in whatever fashion. And these need to include the facts about what is this disease, how is it transmitted, a list of updated countries that are affected, particularly for travel policies. People need to know about sick leave, what things have been put in place within management and HR regarding sick leave of workers. We need to establish a blame-free work environment for our staff, just in order to tackle this pandemic that is now coming to our borders. We need to have a climate within our workplaces that looks not to punish people for staying away from flu, which may be a way of controlling and preventing the spread of this disease. We need to, where possible, make it that people have access to work from home. And also, you know, the travel risks need to be understood, travel policies need to be updated, and informed decisions need to be made looking at the risk and the benefit of traveling within each company. Okay? Just to reiterate again, there's a public hotline number of NICD, it's 0800 029 999. There's also an NIOH number with regards specifically, you know, we will direct you to the NICD hotline when it comes to clinical management of patients. But with regards to looking at processes to control the workplace, it is 0800 111132 when you need any information, additional information. But there's also an email address that we'll give you at the end. Okay. So now we go back to basics. You know, we spoke about information that needs to go out to employees. But within our workplaces, according to our legislation, we need to do, according even to the Occupational Health and Safety Act, we need to do risk assessments in our workplace, okay? And so our Occupational Health and Safety Act says that we need to have a risk assessment. It needs to be done every 2 years or so, but in the event of something changing in the process, in the risk, we need to redo our health risk assessments. And this is a real threat that is coming into our workplaces. So now is the time to redo our health risk assessments, and to determine the risk of exposure to COVID-19 in our workplaces. But we mustn't do this in isolation. We mustn't only look at COVID. We need to look at, do the risk assessment as what are the hazards in the workplace, and try to identify all hazards in the workplace, be them biological, like COVID-19, or any other biological risks that we have, be them physical risks, like the usual lighting, noise, all those kind of risks, as there are risks to chemical hazards in the workplace, ergonomic hazards in the workplace, and also we mustn't forget about the psychosocial impact that is potentially causes us a risk with dealing with COVID-19. We could, depending in a healthcare setting, there could be exposure to long working hours now to take on the burden of the disease that's coming in through health facilities. There could be psychological distress, fatigue, occupational burnout, stigma, you know, even within healthcare facilities, you know, violence and physical and psychological violence could be a risk to our staff that we may face. So we need to do a thorough risk assessment again. And this risk assessment, we need to look at specific jobs. So workers, even working in the same environment, in the same workplace, different workers have different risks. So we need to specify for our workers. So it needs to be a job-specific risk assessment that needs to be done, because this is our starting point. When we are able to identify the risks that each of our employees face, we can then look at ways to control that risk for each of the employees in order to mitigate the risk. So there's many, COVID-19 causes many risks or consequences for the employer. And a lot of the time the risk is unknown, who's going to come in. And so it is a bit of a challenge to assess, assessing the risk. But where people who we don't know, where we have interaction with people who potentially have COVID-19 disease, we need to assess that risk and log it appropriately. There could be disruption of services because of COVID-19 disease, and it could impact schools, it could impact our service delivery. There's quarantine and absenteeism, so it could decrease our service that we're giving out. It could increase our expenses where we need to look at having additional staff to replace the ones who are missing. Looking at audiovisual and technologies in terms of where we need to ensure that people have the ability to work from home, access to equipment and maintenance of this equipment, and there could be work-related diseases due to COVID-19 that puts a burden on the employer. Okay. There's also risks to the employee. There's a risk of exposure, infection, there's a financial risk with regards to medical aid, sick leave, being exhausted, having to take other types of leave. Where there's no medical cover, then needing to go to a public healthcare facility, which is already overburdened. Also to transmission of asymptomatic workers to their colleagues. With regards to mental health implications of COVID-19, it could lead to depression, anxiety, panic around COVID-19. And then if somebody does get infected and needs to be rehabilitated and accommodated within the workplace. So there are many consequences of this, not only to the employer, but also to the employee. Now, how do we control these risks? We've identified it. We need to have a prevention plan. We need to be able to mitigate these risks in the workplace. And we like to talk about primary prevention. And our primary prevention is ways of minimizing the risks in the workplace, which, like we said, we start with the health risk assessment, identifying and assessing the risk. Okay? And assessing what controls are already in place and what controls do we need to add in order to even mitigate that risk further in our workplaces. And we'll talk to the different ways of controlling risk, be it engineering controls, administrative controls, and as a last resort, PPE. And then we need to have business contingency plans because we still need the services to go on oftentimes. We need to have policies in place to be prepared in our workplaces. We need to, like we spoke about, have education and training. And then we also need to look at secondary prevention strategies. And these are when there's someone who presents with signs of infection, we need to respond early, isolate early, treat appropriately. Okay? And then if somebody does get COVID-19 disease and get sick, we need to have tertiary prevention strategies in place, like looking at rehabilitation, looking if it is a workplace-acquired disease, looking at areas of compensation, and also looking at appropriate leaves. So management should take the lead on occupational health and safety and the public health approach. And, there have been many recommendations that have been done. Schools have been closed. We have been bombarded with messages of how to have clean hand washing and hygienic work practices. Hand washing, sanitizing, which we're going to talk to a little bit later. Education and awareness campaigns. We need to look at travel considerations that we already spoke about. We need to advise our people about flu vaccines, have and only use appropriate PPE in the right setting. We need to do a policy review of our occupational travel policies when necessary. And within our workplace, we also need to think about different ways of doing things, avoiding mass gatherings, changing the process of how we work to accommodate and mitigate for this risk. Okay. So when we're looking at travel in the workplace, we need to, regarding travel, we need to be informed. There is an NICD website that is constantly updating about the high-risk travel areas. We need to deem if it's necessary, if the risk that we're taking or we're allowing our employees to take is actually necessary for company business, or if it can be just avoided and put off for the shorter term. If we have to travel for whatever reason, during travel we need to wash our hands regularly, try to avoid sick people, practice cough etiquette, and truthfully, even though at airports and on TV we see pictures of people wearing masks, unless someone is infected, masks are not helpful. Okay. And then afterwards, we need to quarantine if people are in high risk and have already, like our president said, that people who have traveled need to be self-quarantined for 14 days and need to be monitored. If symptoms develop, they need to self-isolate until there's a negative result. Okay. In terms of education and training, we spoke a little bit to this, but we need to give people facts, but particularly in the workplace, we need to give people facts, how the disease is transmitted, infection prevention and control, and hand and respiratory hygiene practices. We need to, when necessary for people to wear PPE, we need to have the proper donning, putting the PPE on and doffing, taking the PPE off so we don't contaminate ourselves. And the disposal of PPE is essential to be in specified bins of hazardous waste so that it can be taken to the appropriate way. We need to advise workers on self-assessment, on symptom reporting, and on sick leave policies. We need to tell people about the benefits of influenza vaccination, and we need to make it possible to work from home and allow for people to have sick leave when necessary. Okay. So just recapping, we spoke about our risk assessment, which is our mitigation factor, just to identify and assess the hazard. We then need to look at the engineering controls. Within the hierarchy of control, the first step is to eliminate the hazard. I wish we could, but we can't yet eliminate COVID-19. Substitution is not quite appropriate. Then we need to look at engineering controls, right? We need to look at the types of engineering controls allows us to isolate the employee from the hazard. And it doesn't rely on worker behavior. And so even though it's costly initially, it can be a cost-effective solution to prevent the consequences of people becoming infected. So some of the engineering controls that have been recommended for COVID disease, and some of that is high efficiency air filters, increasing ventilation rates, and it's important that within our workplaces we open the windows where necessary. You know, we do basic things that we can to ensure ventilation occurs, even as we're going into winter. Where it's possible, we need to install physical barriers at our point of contact. So if we have a reception and the public is going to come to this administrative staff or the receptionist at the desk, we need to think about installing a physical barrier to protect the worker. We're also in specialized settings where patients are coming into our facility and we need to do aerosol generating procedures like healthcare workers would need to. We need to think about negative pressure ventilation. We need to look at basic things also like controlling access to high-risk areas, and also there are cleaning devices like UVGI that also have been recommended, particularly in the healthcare setting. Okay. We spoke a lot to this already in terms of administrative controls, and we need to look at all workplaces working within their management team to have a workplace plan, a clear infection prevention and control, and standard operating practice using standard precautions. We need to have occupational health and safety policies. We need to control access, particularly in healthcare workers. We need to look at appropriate triage, have isolation rooms should there be a person within our workforce that says they are now presenting with symptoms, so that they can be isolated and go on for treatment rapidly. We need to ensure proper signage, proper travel policies, cleaning and disinfection procedures. We need to ensure safe waste management. The occupational health, as well as the infection control personnel, should establish points of contact and should have flow diagrams for referral pathways should the need arise. We need to establish public health reporting procedures that are established. We need to fit in line with them and they need to be followed swiftly. We need to have a blame-free working environment and have access to employee assistance programs where needed. Okay. Now going on to PPE, personal protective equipment, which we left for last because it is not the first line of cause, it's not the first point of cause to tackle this pandemic in our workplaces. PPE is only effective if it is within a complete package of mitigation and control strategies. And the type of PPE used needs to be based on the risk assessment. So in the case of a healthcare worker, it should be gloves, it should be a disposable gown, it needs to be respiratory protection, particularly if you are involved in aerosol generating procedures, and this protection needs to be fitted and appropriate. There needs to be eye protection in a healthcare setting when you are actually treating and caring for a person who has disease. So based on that risk assessment, that would be a high-risk employee. Those are the kind of protective measures that need to be in place for high-risk workers. And then PPE that is used should be considered contaminated and discarded in accordance with safe practices. Okay, surgical masks are only recommended for patients who are symptomatic. But for anyone else, asymptomatic people within the community, no PPE is recommended. Okay. So with regards to medical surveillance, okay, as the HPA regulations state, an initial medical evaluation should have been done and periodical examinations may be needed. But these are in situations where the HPA is known and is capable of causing persistent latent infections that are diagnosed with long incubation periods, not like this one. It can result in an illness which is recurrent despite treatment, not like this one, and are known to have serious long-term effects. Okay, so that is, so it's not really applicable for workers who are not in high-risk settings. Okay, high-risk settings, workers, medical surveillance is used to ensure early detection of disease and to facilitate people being tested and treatment occurring. And this may be relevant in the case of healthcare providers and people who are at high risk when treating exposed individuals or infected individuals. Okay, and in these settings, the medical surveillance can include monitoring of symptoms and temperature checks, but this has to be, I can't say this enough, it has to be in line with the risk assessment. There's no need doing this unnecessarily for people and creating a panic or creating a need for this in the workplace. It only needs to be done in high-risk individuals, and this risk needs to be very specific to the worker, and it needs to be at the guidance of the company's OMP. Okay, so it's only applicable for high-risk staff, possibly like healthcare providers who are treating staff or treating patients with COVID-19. Okay. And then we also need to think about tertiary prevention, rehabilitation, appropriate COIDA compensation applications if needed, and we need to address leave issues with our HR. So it has to be said again, regular, thorough hand washing by employees, contractors, customers. Please, let's do the respiratory hygiene. Tell our staff about that. Avoid touching your face, especially while you're working. And people who are symptomatic need to stay at home. Okay. This is just pictures of prevention practices. Also need to rethink our mass gatherings, our trainings, how we do things. Waiting areas for medicals, meeting rooms if we're meeting. We need to consider the method with regards to medical surveillance, that is ongoing medical surveillance that we do in companies. We need to consider the method. We need to assess the risk for our employees that are undergoing this surveillance, as well as for the staff that is administering the spirometry or the breathalyzers. And we need to think about also within our workplaces, how do people get access? Access control methods by biometrics in terms of fingerprinting, signing in, all those contact points that could be possible ports of infection. Okay? So if you suspect you have been exposed, there needs to be something in place in your workplace for all employees who suspect it, to alert their supervisor, alert occupational health. Probably better off for them to stay at home and inform their healthcare provider or the NICD hotline. There's the NICD hotline. It's 0800 002 9999. That is for clinical queries. Please feel free to, there's also a health worker related hotline that's available on the NICD website. If you have any work related questions, there is the email address info@nioh.ac.za. Thank you for your attention.
Well, thank you very much. Thank you, Odette. That was my colleague, Dr. Odette Volmink. We will deal with questions when we have our full panel here in front. So that was dealing with the latest update on COVID-19. What is it and where are we? And the COVID-19 workplace preparedness and prevention. Our next contribution is from Dr. Pumin, sorry, apologies, Jeanette Mangani, who's going to look at the respirator fit testing. And please ask your questions in order for us to be able to assist our colleagues back at work in order to deal with this. Hi, Jeanette.
Thank you very much, Ashraf, and thank you to Dr. Odette for laying such a great foundation. I just want to mention that the contribution that I'm just going to make, some of you may be familiar with the concept, but because we received a number of requests, we felt it's ideal to be presented in this platform. So those of you who are going to be familiar and you know a lot of the information that I'm going to be sharing, please bear with us. We're doing this for those who don't understand the concept. And this concept was also born from most of the conditions and which have been explained by Dr. Odette, that if you are expected to use a respirator, it has to be a fit tested one. So as a start, this is who we are, what do we stand for, and if you need more information, I'm really reiterating on this slide. And I'm going to be talking to you under PPE, but my focus will be on respirators. So I felt it's very important that I should share with you some of the questions which has been asked recently after the situation, COVID-19. So the first one, which I did not list here, is most people, like especially healthcare workers, have been requesting the sequencing of donning and doffing of respirators or PPE, all of PPE in general. So we do have a video clip on that. So if you happen to be interested and you want to know about the protocol, please drop us an email requesting that we send you a link so that you can access it. We're not saying that that is a link that can be adopted as it is in your organization. You can learn from what we have captured there and you really refine it to suit your setting. So other questions that we've been receiving is, where do we get PPE? So as an institution, we're not specifying any suppliers. We are saying that you must keep your current suppliers. And if your current suppliers are not having PPE which you are requiring, so go to the South African Protective Equipment Marketing Association. They have listed different members who you can contact so that you get what you need. And again, that is based on your organization processes, because sometimes procurement may need to keep what suppliers you have, but currently you need to really relax some of the procurement processes so that you can add some, or maybe you can be allowed to purchase from suppliers who are likely to have what you require. Then questions like who should wear PPE? Dr. Odette has addressed that, and it is based on the risk assessment. We don't have a blanket answer for that. So in this case, in relation to COVID-19, she spoke about those people who are likely to be exposed to an infected source and those who will be involved in a procedure which can cause some aerosolization. So in that case, if you are expected to use certain types of respirators, PPE, including the respirator, so just check based on your risk assessment, the outcome should specify for each and every job profile what is needed. Then, and again, it's who should wear which PPE. Dr. Odette spoke about that. There's also a question about the difference between a mask and a respirator. So she also mentioned that there is also a criteria with COVID that if you are symptomatic, you want to see your healthcare provider. As a precautionary measure, you may need to get a surgical mask, which you can put it on and you phone first and you prepare your healthcare provider. Going there wearing a mask so that also the healthcare provider can get a respirator to be ready to see you should you happen to be infected with the virus. So the difference between the two, I know we use this term interchangeably. We often call our N95 or FFP2 masks. They are not masks. there are respirators. There are filtering face piece respirators. So mask is a surgical mask, which you hook on your ears or you tie at the back of your neck. So WHO has recommended N95 and FFP2. So those are the two respirators that I'm going to be spending time talking about. How do we make them to be more effective in terms of respirator fit testing? In terms of the effectiveness of the PPE, we need, based on our risk assessment as well, we will look at how do we discard the gowns and the gloves, and we make sure that whatever we use, it shouldn't end up being the source of contamination or infection. So in other words, we need to use this PPE provided to us the right way, and we make sure that we prevent it from getting contamination and end up getting exposure from PPE, not necessarily from the infected source. Then there are also requests coming to this institution that there are new respirators, there are new PPE. How do they get these respirators specifically certified? Then again, we send people to national standards, and there is a link that I will show at the end or provide if you really need to know about that. But in this institution, we don't certify products. So you need to get your product certified before you supply or you distribute to users. Then I will also clarify the issue of seal check, because it's often confused with respirator fit testing and also as filtration efficiency testing. So seal check is what you do every time when you wear a respirator. It's more like you're fixing it to make sure that it's sitting properly. But when you do seal check, in other words, you've already confirmed which is the respirator that is fitting you properly. And respirator fit testing, that is the test that is used to confirm if the size and the type can fit you. So that is what I'm going to be talking about. The filtration efficiency testing, it's one of the tests that happen in a laboratory area when they are still testing the product. It includes the breathing resistance, the fire resistance, the fluid penetration resistance. There are a whole lot of tests that happen in a lab set up before the respirator get approved for use, for distribution to the users. So in other words, you must be careful not to use PPE or respirators which are not certified or which are not approved, because in other ways they may not have gone through these processes that I'm talking about. So there's also a question, who should be responsible for supplying PPE? Obviously, that is the requirement from the employer and free of charge. So you need to consult your employer. And if they can't find stock because there's shortage of stock, does not mean that the employer are not providing to you. So you need to understand why you don't have, instead of assuming that the employer may not be able to supply those PPE to you. And it's also the responsibility of you as an employee to make sure that you use the provided PPE, because that is based on the outcome of the risk assessment. Then if you're not using that, it means that you are failing to account to your responsibilities. So it's very important, and you must make sure that all policies regarding reuse, discarding, and so forth, you adhere to those so that you are fulfilling your responsibilities. I just want to also mention that the culture of adopting the hierarchy of controls. So yes, Dr. Odette spoke about the control measures which we can consider. We're also receiving requests or queries regarding the ventilation means. Then we know that, with the droplets, if we can get the droplets to dry quick, we can use simple natural ventilation by opening the windows. So we do have other means apart from using the PPE, but we do understand that in a healthcare setting and with the situation at hand, we may not avoid the use of PPE. So that is bringing me to the topic of respiratory protective equipment use and COVID-19. So the group that I'm going to be talking to in terms of respirator use, which is either N95 or FFP2, is those group who will, based on the risk assessment, who will be in direct contact with the infection source, or who will be expected to perform procedures or aerosol generating procedures where they are likely to be exposed to contaminated droplets. So ideally, some of you who already are aware of the concept, I'm sure you will agree with me that the element of respirator fit testing fall under the respiratory protection program. And among other elements, it includes the policies where the management support the program and make sure that we have respirators available and the risk assessment conducted to identify those who are required to wear the respirators. And also employees buy-in where you are involved as well and in the process of respirator selection. Also the concept of medical evaluation we need to understand, because there are those who struggle to use respirators. So if you will be expected during the situation of COVID that you cannot be able to use a respirator, it's very risky because you may not be able to work with the respirator while you're wearing a respirator. So that needs to be picked up. And I know there are some of the OMPs, or Occupational Health nurses, who have just joined. There is a checklist that OSHA is using. They can evaluate if people can wear respirators, like those who are asthmatic and those who have a breathing problem. So you need to identify those, because it does not help to get people to use a control measure that they won't be able to use in the workplace, and that defeats the whole purpose. So training and information is very important, because people need to understand the limitation of any PPE that you're going to give them. Because if they don't understand, then they are likely to make a lot of mistakes, and now the effectiveness of the control is really not going to be achieved from the product itself. So we need to make sure that we inform them and we train them properly in order to help them understand the control measures in place. So users, it is recommended that they are fit tested before they are expected to use a respirator. So in this case, I just want us not to blame employers or you blame whoever is requesting you to use a respirator that respirator fit testing has not been conducted. We can start now. If you are expected to use a respirator, you need to ask your employer, you need to ask your supervisor, and how can this be done? So I just want to dwell into the concept, as I have promised that the idea to present or to contribute now, it was to really unpack this concept. So respiratory fit testing is a test which is used to really specify which type or either model or brand, and even the size of the respirator that can adequately fit a specific individual. I know some of you who are not familiar with the concept, you may not know that some respirators come in different sizes. Like the N95 come in 2 sizes, in small and medium. The FFP2, as far as I'm aware, it comes in 1 size, which is a medium or regular. So you need to be aware of these things so that when you make a different types of respirators available, so that people can be fit tested in order to identify what fit them better. So the reason for doing this test, we want to make sure that employees are confident that they are provided with a respirator that provide a better protection. Then we want to confirm if there is a fit between the person, the user, and the infected source. And while you're doing respirator fit testing, it gives you an opportunity to identify some gaps. Like if your employees are still into correct donning and doffing of a respirator. So you can correct there, and sometimes it can really inform you to do another training. So you will be able to identify those gaps and correct accordingly. As I have mentioned, then ideally your respirator fit testing, you must do it during the initial selection of a respirator. But now we have a new hazard identified. So if you were working in a different department, now you are expected to work in this department where you are likely to be exposed to coronavirus. And now it means if you were working in a chemical lab using a different respirator type, now you need to be fit tested with this one, which is in line with the hazard or the purpose. Then after this, you can decide based on your organization policies, or you can adopt best practice and you do respirator fit testing as part of your refresher training. I don't know what's happening with this. Okay, apologies about that. So anyone can do fit testing. They just need to have knowledge and training, and then you can ask your PPE suppliers. I know that there are PPE suppliers who have this respirator fit testing kit who can help you. So fit testing can be done either qualitatively and quantitatively. However, CDC, they are currently recommending qualitative fit testing because it minimizes the destruction of respirators during fit testing. So when you do quantitative, the one on the right, it requires us to probe a hole on the respirator, and that respirator needs to be discarded after the test. So in other words, if you're fit testing 100 people, you need to discard 100 respirators, which are actually not necessarily used in a workplace. So I do really agree with the concept of where possible, we are not advocating one or another. Where possible, you need to know of the limited resources around this. Okay, so there are factors which can affect a fit, irrespective of fit testing, which confirm whether you got a fit or not. So people who have facial hair and beard, they have challenges because it doesn't matter what respirator type or size, it will not fit them. So if the organization is faced with such a challenge and these people are expected to be protected from the respirator, they can consider the powered air purifying respirators, which are like loose fitting respirators which do not need to be fit tested. However, these should be coming from organization policies. If you wear the respirator incorrectly, that it won't really help you to be protected from the hazard that you're trying to prevent you from getting exposed to. So you must make sure that if you have identified a respirator which fits you, every time you must make sure that you put it correctly and you do the seal check to confirm that it's set properly. As I've mentioned, incorrect size and shape in relation to your face type, that is always a challenge. Hence, fit testing will confirm those factors. If you have facial deformities around the seal area, those need to be confirmed that they are not really allowing any gaps, which may really pose you to being exposed, even if the respirator is suitable in terms of the size and the shape. As you have seen, Dr. Odette spoke about different types of PPE which are required for different responsibilities. So in this case, if you are expected to wear like your coverall or your gown, or you need to make sure that, or your safety goggles as well, you must make sure that your respirator is compatible with those other equipment. Hence, it's very important that if you need that protocol, it's important because you know which one comes first. And also when you doff it, you know which one, what sequence you should follow, so that none of the PPE affect one or another. In terms of multiple donning and doffing, that can also, people tend to relax. When they don for the third or fourth time, they tend to put it much bigger and then don't fix. So just conscientize yourself that even if you're wearing for the third time, you need to really be careful not to really skip some of the procedures because you may continue with the task that may be hazardous to you and you're still not protected. Okay, I also want to address the issue of reuse because it's being spoken a lot because of COVID and with the limited stock that we have. We are all aware that manufacturers' instructions they are given in whichever PPE or the package or the box. When you get your respirators now, the box specify for respirators is single use only, but it's not realistic considering the situation at hand. So based on the risk assessment, you need to make sure that when you reuse, you must make sure that you prevent contamination during redonning. And again, when you store, you must make sure you store it in an area where you're preventing it to be contaminated. Again, CDC strategy for optimizing the supply of respirators. They're recommending extended use. In this case, you wait longer instead of removing it and redone. So, but they're saying you can do extended use up to 4 hours. But again, they also sensitize us that we should make sure that we avoid discomfort. So in this instance, you must realize that those people who can't wear a respirator for an hour, they may struggle. So you need to pick those people and you see how you can support them within your organization. So this concept is very important because even if you provide a respirator to a person, but if the user and respirator match is not checked, we may have a poor fit, even if you are wearing the respirator, which is correctly selected for the hazard or a purpose. But if we apply this concept, we will ensure that a proper fitting respirator is provided to the user, which will reduce exposure and therefore will be able to reduce the potential of infection. Thank you very much. These are some of the sources of information which I've used. You will see even the dates which I've accessed them. So if there are changes, this presentation was compiled based on the information that was relevant during that time. Thank you very much. If you have more information, I would like to reiterate our email addresses.
Thank you very much. That's our colleague Jeanette Mangani, who's dealt with the respiratory fit testing. We'll deal with questions afterwards. I immediately invite my colleague Dikuledi Matuka. She'll deal with the question of maintaining the clean workplaces in order to assist us with this national state of disaster as declared by the state president on Sunday. Welcome, Dikuledi.
Thank you, Ashraf. Good morning, everyone. I'm going to present to you the cleaning procedures, which is the most critical part of infection prevention and control, because we need to keep our environment clean so that we mustn't contaminate ourselves, and also to protect the worker from exposure and from infection. So the use of correct disinfectant is important in preventing and reducing the spread of disease. Disinfectants may not work on all surfaces because we get different surfaces. You get the porous, the semi-porous, and non-porous. So there are other alternative methods for decontamination for those that where disinfectants cannot be used, such as your steam sterilization or steam cleaning, or you can also use other devices that can decontaminate in areas where contamination is suspected. Some disinfectants can also be toxic. So before even applying these disinfectants, first risk assessments need to be done, and then most importantly, the staff needs to be trained on how to use these products and also on their hazards and risk they could be exposed to. And the products can also be expensive. Therefore, users should also involve procurement services or their financial departments for these purposes.
So the World Health Organization and the CDC recommend that appropriate disinfectants with proven activity against envelope viruses, in this case that's COVID-19, be used to minimize the risk of transmission of the disease. Examples of such active ingredients include hypochlorite. There was one question on about that. So you do get the hypochlorite concentrated. So the user, it's important to know the percentage on the container of the concentration of that jig, so that you know at what ratio you should mix the jig and water to end up with the solution that you need to use to clean the surfaces or the environment. So another one is alcohol, which should be at least 60%, but preferably 70%. There was another question on that as well. So 60%, sometimes you do get the suppliers who will put on a percentage like 60% or even 40%, but you must make sure that they have another active ingredient which will boost the alcohol. So it's important to get the MSDS from the supplier and request explanation on how it works and how these two ingredients can work together in order to achieve the disinfection rate. The third one is hydrogen peroxide. I think there was one question on that. So the concentration also, or the percentage used, will depend on the supplier or the manufacturer as well, which is why it's also important to refer to the MSDS to see at what concentration will this disinfectant be effective in killing the virus. Phenolic compounds also are such active ingredients that can be biocidal, as well as quaternary ammonium compounds. At the end of the presentation, I'm going to show you the slides which list registered disinfectants that can be applied in the work environment. So the reagents I've mentioned, they can either come undiluted, where they are concentrated and you need to dilute yourself on site, but it's important to note the ratio also of mixing your reagent and diluting it with water. And then the diluted ones, the manufacturer sometimes prepare a ready-to-use solution. So the user must be careful or be cautious to check on what the manufacturer says on their product. Check also the label, can also direct you on that. But if the label it doesn't give you detailed information, then you have to ask for the MSDS and refer for more information on that. So they come either as surface disinfectants in the form of liquids or powder, which you need to dilute, and then surface wipes as well. But there's some literature that states that surface wipes sometimes may not be effective in killing microorganisms on surfaces. So again, we need to verify with the supplier, as wipes also sometimes tend to dry out quicker. So the concern there is the contact time between your wipes and the surface to be decontaminated. So it is recommended that the frequently touched surfaces be disinfected regularly. Examples such as the shared equipment or undedicated. Sometimes in the workplace, the instrument can be moved from one area to the other. So those need to be disinfected so that you don't move contamination from one area to another area. Your doorknobs, where we always touch, some people touch with even contaminated gloves. Your desk or your countertops where you usually work. Bed rails, for example, in hospitals, or the other rails of the stairs and so on, and bathrooms, etc. So disinfectant can also come in the form of antimicrobial soaps. That's for hand disinfection. And you can also get the gels and wipes. So the hands needs to be clean before you touch the door, as door is used by everyone in the workplaces, and also at regular intervals. Depending on what you do, you know, it's recommended that before you touch a clean area so that you mustn't contaminate, make sure your hands are clean, and after touching the decontaminated surface or being in contact with surface that has been decontaminated, or a patient, for example, in healthcare. The gel must always be allowed to dry. After rubbing the gel in your hand, you let it dry, and then it's not necessary to use the water after using the gel. But again, you have to refer to the manufacturer instruction. So it's important also to note that the worker or the user must use proper hand wash technique as recommended by WHO for healthcare workers, for example. Those 5 moments of hand hygiene can be applied. But the important thing is to make sure that when you use soap, for example, you make sure you lather on your hands and cover the entire hand, and reach out to the hidden roots as well, and make sure you rub under your nails as well to get rid of all contamination. So dirty surfaces must be cleaned with detergent and soap before the disinfection procedure takes place, and disposable gloves must always be worn when cleaning the environment or when disinfecting the surfaces. After using the gloves, they must be disposed of properly in the correct bin. If reusable gloves are used, they should be dedicated for that area or for that procedure in order to avoid transfer of the microorganisms to another area. And if it's reusable, you're going to use them again. You can have a solution of a disinfectant where you will also soak those gloves for a while, and then after disinfection, you let them dry in preparation for reuse again. Adequate supply of cleaning materials should be made available for healthy hygiene practices, because we want to protect the worker from exposure and we would like to keep our environment clean. So it's important to also note, when it comes to disinfectants, effectiveness plays a very critical role. So that can be affected by several factors. Firstly, the concentration used. So the manufacturer will indicate at what concentration the disinfectant must be diluted to, because different suppliers will have like different concentrations based on what they have tested. When they did the effectiveness test, they exposed these reagents to certain microorganisms, preferably the ones that's hard to kill. Because if you can target that and be able to inactivate that, it will be easy to kill the other organisms. So pay attention to the label and the manufacturer's instruction. You'll see some containers will show you the percentage as indicated on the slide. It will either show you 99.9% or it will show you 95% and so on. The ingredients or the composition of a disinfectant is important, as I've mentioned on the previous slide. Alcohol, for example, is recommended, but some boost it with other active ingredients, as stated. Storage conditions also is critical. The temperature at which the reagents are stored can affect the disinfectant and make it lose its activity. So if you use it with declined activity, it means it's not going to do its job that it's supposed to do. The method used must be followed as per SOP or the product label. The volume used is important. I'll show you on the last slide as well. For example, some recommend 2 ml for hand gels. So it is advisable because it's not easy to measure 2 ml when you are just in the room. So it's advisable that before you even apply the gel, estimate using a measuring tool cylinder and then see an estimation of the amount of the 2 ml gel on your hand, so that in future you can know more or less on how much to put. Others say 2 ml or 3 ml is equivalent to a 1 push of that dispensing bottle. You'll see on the last slide. So the other critical point is the contact time. The contact time is the time at which the disinfectant must remain in contact with the surface. So that will determine the effectiveness on how this specific disinfectant will kill the organism. And some containers or suppliers will also show you which procedures or standards they meet when they produce their products. So pay attention to that as well, either on their certificate of product or on the MSDS or even on the label. The last point on safety has to be considered also, especially for the user, as mentioned on the initial slide. Check your MSDS. If the product doesn't come with MSDS, ask the supplier for the MSDS, because that will give you the entire information on what is the product made of, how much concentration is there, and how to dilute, the precautionary measures to take when dealing with these agents, what PPE to put on as well, and the environment or environmental conditions on where to apply this disinfectant. So MSDS is an important document to look at when you receive your product. After using the disinfectant, it's important to wash your hands as well as moisturizing your hands, as some chemicals can cause skin irritation to your hands. So you want to moisturize your hand to keep it moist and from dryness. And when you're using disinfectant in the room, it's advisable to make sure there's adequate ventilation. And that can be achieved in the form of opening windows and supplementing with aircon to make mixing, or if there is mechanical ventilation, that can be used as well, but it's cheaper to use natural ventilation by opening windows. Users should be trained, that's emphasized, on their hazards they are exposed to, the risk of using the type of disinfectant, and what to do in case of emergency or exposure. And they should be provided with the appropriate PPE. Okay, I've extracted this list from the list of the EPA registered disinfectants. This is just a portion of the information. There's a whole long list of disinfectants, but because we're dealing with the coronavirus, I thought it would be critical to show this and to emphasize the importance of contact time. As you can see from the slide, quaternary ammonium, which I've mentioned as one of the examples which WHO recommend as a disinfectant active ingredient that is effective against enteroviruses. It requires 10-minute contact time in order for it to kill the virus. And as we go to, at the bottom, you see hydrogen peroxide and peroxyacetic acid as well, which needs a shorter contact time. So depending on the activity at hand, whether things are moving faster or you still need to have time to do something, you'll base your choice of disinfectant with the contact time based on that. So you would go for a shorter contact time for processes that go faster so that you mustn't get delayed between the process. Or if you have some time, you can choose those ones, depending also on the cost of the disinfectant and the preferable one. So each workplace will use the disinfectant which they have chosen to use. So we will have different procedures or SOPs for different settings. So it should be up to the users and the management probably to decide on what disinfectants to use for the institution or for the facility. You see this list is being recently updated as there's disinfectants that have been tested and have shown or proven effectiveness, they add on the list. So this is just an example which I thought I should put in just to drive some points through. As you look at this chemical or disinfectant, It states that it comes undiluted. So it's not, it's concentrated basically, so you will need to mix it with water to make up your solution. And this is where it mentioned that your 1 pump in the bottle is equivalent to the 3 ml. So that's important information to guide you on the amount that you will use for effective hand sanitation or hand cleaning. And then it also states that the contact time is 1 minute, which is great because it's quicker. But this container doesn't show any expiry date on it, because disinfectants also, they'll give you the shelf life on how long it will take while it's active. Even when you have to dilute it, they will either tell you dilute it immediately when you're going to use it, or if you have diluted it, it's going to last either for 10 hours or for 24 hours. So that's also important information to pay attention to. And then lastly, the percentage alcohol is not indicated on the container. The active ingredients are shown. There's ethanol there, there's isopropanol, but it's not showing the percentage. I didn't have the MSDS for this container, but probably it will be indicated on the MSDS. But it's not long test, so I would have preferred it to be on the bottle so that it's easily accessed. Okay, lastly, these are just the recommended sites that one can go through. There is a lot of information. For example, the CDC has got a guideline on disinfection and sterilization. So you can find different types of disinfectant there, or the active ingredients that are being used for certain products. The EPA has a long list. If I've shown you just a portion of the list of registered disinfectants. So you can visit all this website and you'll get all the information. Thank you for listening, and then we'll receive your questions and hopefully we'll answer them.
Thank you very much. That was Dikeledi Matuka talking about the importance of cleaning procedures. I'm not sure, am I still in the picture there, Glenn? Okay, there we go, yeah. So, we are now just bringing the chairs closer because you've sent us quite a lot of questions. Some are perhaps a bit duplicated. We've covered some at the beginning. I'm asking my colleagues just to all take a seat behind me. They've kindly just put the seats in place, and then we will proceed to the question and answer session. Just a reminder, for those who joined us late, who've not yet placed the email addresses, names, and a contact number and so on in the organization you also belong to in our chat bubble. Unfortunately, at this point in time, I think we may not have enough time to take any more questions. We'll deal with the questions we have there, but do remember, there is a slide that my colleague Glenn from IT will pop up again with all the details of links to resources, including our email address. And that email address is info@nioh.ac.za, info@nioh.ac.za, and there you could also pose your questions to us directly. We now do have a hotline in place as well, and that hotline will also appear on your screen, and that is 0800 111132, 0800 111132. I'm going to now allow my colleagues to immediately start with the questions as to get mine. Okay. Can you also show us the questions there for them to also see? Thanks, Glenn. So one of the first questions that I have, let me just go up, and there was questions that we had redirected earlier, Odette, to our colleagues here, and I think I should get myself a chair. Maybe I should sit aside. Okay. Was it about the testing of surfaces? Yeah. So maybe I should start with that one. And it was covered by our presentation today. Is there a way of testing surfaces of arguments that in the hotel? And I think, Tanisha, you dealt with that question. What other alternatives can be used since alcohol sanitizers are out of stock? Was it addressed by our presentation in terms of the alternatives? A quick reminder for us on that, Tonika?
Okay, can you repeat the question again?
What alternatives can be used since alcohol sanitizers are out of stock?
Okay, as recommended, firstly, the first step is hand washing. That's critical with soap for 20 seconds. If sanitizers are not available, currently we don't have the context of who, like for contingency, who will be making the sanitizers, but we're investigating that if we can get more
Stock and supply.
Yes.
And there is a means for people to be able to say, here's how you can make your own.
Yeah, there are formulas available. As mentioned, it has to have certain ingredients in it that can be effective against the viruses.
So they are,
Tanisha?
they are formulas, as Monica mentioned. We are trying to establish and find a laboratory that can vet that to determine whether that recipe is effective. You know, and then if that is, then we will share that recipe.
Okay. The next question is, so we'll get it up there, apologies, I had minimized it a bit there. So getting used to the technology. Effectively, we need another screen here just for the questions. So please indicate if you, okay, that's me asking people if they can indicate, if they can see the video. 1 second. So how can people test their temperature every day if they don't have a thermometer? I mean, do we deal with that at the NICD? We did, right? And there's the formal guidance with regard to routine diagnostic testing in our setting. Will the NHS release formal guidance? We've referred to the Department of Health guidelines.
Yes, and there's a guidance on NICD with regards to diagnostic testing. And it's available on, there's a technical guidance documents available on the NICD website that you can download.
Are you specifically referring to the Department of Health SOP?
There's a specific one for the
Okay.
NICD.
So we will flash later on again the links to the NICD website in order for you to go and find these particular guidelines there. That's specifically to the question that is being asked by Lawrence, I think Lawrence Jacobs. What is the appropriate PPE for occupational health practitioners? Will be the first point of contact for an employee. I think we dealt with that particular issue. The importance of the risk assessment is important, and the risk assessment will indicate which people are more at risk than others, and what do the appropriate PPE.
And I think she does mention there in terms of who is first at risk with treating a patient, and that would be a gown, disposable or non-disposable. 1 pair of gloves is appropriate. Eye covering, not spectacles, but an eye shield or eye goggles that covers the entire face.
And for which setting would this be? Would this be?
She mentioned someone who is treating COVID-19 patients.
So this is high case scenario.
Yes, and also a respirator, N95 fitted respirator is the ideal one.
Another question deals with the setting of the lab, right? What is the appropriate PPE to wear in the lab, assuming there are different types of labs? What are the scenarios for different types? There might be the lab that does the actual testing where there could be a biological risk, and there may be other types of labs. What is your recommendation?
I think they need to do a risk assessment, like we said. If they work with chemical, they work with HBA, there are different types of respirators which are relevant to the hazard. So if it's a mixture of those, then there is a respirator type which can accommodate and can have an additional element of a filter that make it more comprehensive to deal with a number of hazards. So it goes back to the risk assessment. What are the hazards within the different processes within the lab? So unfortunately, we're not going to say this is the type because we don't know the hazards.
And also it depends on the activity that's conducted in the lab and what containment measures they currently have in the lab. For example, if there is a risk for aerosolization in the lab, then surely they're going to wear a respirator and they will have their gloves, etc. If they have a biological safety cabinet, then they may not need to wear the respirator because they have that protection. So that assessment has to be done. And also bearing in mind there's a shortage of PPE, we need to conduct a thorough risk assessment to only give the PPE to those that really need it.
Yes, so that deals quite. The question about the JIP solution that Esme asked about, linked to earlier question by Dion, we've covered that, right?
Yes.
Okay. So in time, in the interest of time, we would be just quickly go to the. So what about the cases of reinfection recorded? Is there a risk of reinfection, assuming that I was with a lab test, positive, then negative, and then is there a possibility that people could be positive afterwards? Have they been such evidence?
There are cases of where people have been reinfected, but the percentage is very low. I think it's between 1 and 3%. Yeah.
So that may not necessarily be a major concern in our context, but needs to be watched out.
It's something to think about.
So when the risk assessment says these are the basic measures that needs to be put in place, in terms of the hierarchy, that needs to be maintained beyond, and that would ensure that obviously no reinfection should be the scenario, if our systems are effective. Okay, then we have the question, I think it's about how samples are transported by the NICD and MAPU. The question of packaging, manual handling, transportation, lab procedures, and thereafter, the question of storage or disposal. I guess that's the whole cold chain something also asked about.
There are specific SOPs on dealing with samples, packaging the samples, and transporting the samples, and the chain to follow in respect to that is available on the NICD website, or alternatively they can contact the NICD hotline. Yes.
Okay. And do remember, if you have follow-up questions on what we're speaking about now, please info@nih.ac.za. Make a specific reference to a particular topic and what the question is. Be detailed in this chat. I notice people are using a bit of WhatsApp shorthand, and we don't always understand the full context of your question. So the virus is so dynamic, it appears in many forms. That's interesting. I'm wondering what the questioner means there. Are the symptoms the same in all instances or cases despite the form it appears in time it is discovered? I would assume it's talking about the earlier versions as well, SARS and MERS and so on.
Perhaps. The issue about the symptoms, not everybody presents with the same symptoms, but those are the symptoms to look out for. Those are the common ones.
Fine. And I think we need to be very familiar about what's different about this particular virus. And there's, I think, also the element of feeling breathless and fatigued and short of breath.
Yes, headaches, fever, cough, and sore throat.
Okay. Apparently there's hearsay about garlics and alcohol being the cure. What is the exact cure for it? Was it still on the research? Why is it taking so long? Is my impatient asking. So there's a couple of elements there. I guess it's kind of whole remedy stuff going around on WhatsApp, which could perhaps be defined as fake news, I'm not sure. And then the question of the cure and when.
At the moment, we are going according to the guidance from the World Health Organization. I haven't read anything on their website about the garlic. So if anybody wants to use that as a remedy, they need to make sure that it is vetted and credible.
Yeah. Well, there might be things that would boost your immune system, is my understanding, and this deal with that, but it's not equal to cure.
We don't have scientific evidence to say that at the moment.
Anything else you want to add on that? Are you okay? Can we move to the next question? Yes. Okay. So, can one contact, I guess, is this question, the virus again, if it was contacted before? And I think we've covered that question. I'm moving on to the next question. Is there a standardized risk assessment tool available with key questions and guidance to assist prompt interventions? I would assume it's some sort of monitoring tool or some sort of tool that will assist with the risk assessment.
I think they're talking about different tools which people use to conduct risk assessment.
Which are those tools?
So there are different kinds, depending which the organization want to do, like occupational hygiene. They also have different tools, with the HSE tool, which have standardized questions to ensure that the risk assessment is more systematic and to help you that when another person do it, you sort of come to the same agreement in terms of prioritizing the risk. But in this case, I would also want them to be sensitized about conducting a specific HPA risk assessment, because this is coronavirus.
Yeah.
The one that I spoke about is more generic. We also do identification of HPA, but I think the one that maybe Tanusha can elaborate can help them.
But just a quick follow-up on your point, is there any specific regulations that people should take in consideration when they do HPA risk assessment?
Yes, there is. It is regulated that every workplace conduct a risk assessment at least every 2 years, but whenever there's a change in the workplace, like now, you need to review that risk assessment and then put in whatever controls you need to put in to mitigate the risk. So right now, every workplace should be working on the review of their risk assessment. There is a generic risk assessment tool that WHO has, and perhaps, Ashraf, we should make that available to all of the participants on the call to give them some guidance. But there is no standardized tool for every workplace. You're going to have to tailor it according to your specific workplace.
So please don't forget to put your email addresses in the chat space so we can email you and arrange to get these resources to you afterwards. Some may be linked to a link, and then we'll just send you the link and you can access it from a specific website. So the specific regulations I think my colleagues are referring to is the hazardous biological agents regulations under the Occupational Health and Safety Act. South Africa has limited stock of hand sanitizers, which then create a problem for workplaces if there is nothing put in place to sanitize with at gates and reception areas. What must one do to solve this problem?
I think we addressed this one earlier in terms of, there is a recipe out there to make hand sanitizer, because considering the shortage. And there's also a shortage of wipes. Hand wash. There's a general shortage globally. So as soon as we as an institute can verify the efficacy of the recipe, we can share it. At this stage, participants are welcome to search it. It is available on the website, on Google, if you search the recipe for hand sanitizers. But we are not saying that it is effective. We haven't tested efficacy.
There's an international case of an actor who tested positive but did not have any symptoms of coronavirus infection. Your thoughts? My sense is this is the second part of the same, the top one. There is an international case.
Yes.
And the truth is that, it presents with a variety of symptoms, and some can be extremely mild symptoms, where somebody doesn't even won't even know that they are infected. So it does, the severity, it's kind of a range. Some people are mildly symptomatic to moderately symptomatic, and that's the majority of cases that will come up. The minority of cases are those who go into respiratory distress and have severe clinical features, and those requiring ICU admission and then following on to death. So, there is a range, and the majority are in that mild to moderate range.
And just to add to that percentage of asymptomatic people that are positive, they are less infectious compared to those that are symptomatic, because those that are symptomatic are coughing, they are sneezing, so they're producing the droplets. Whereas the asymptomatic ones, the risk of infectiousness is rather low.
Well, we have another PPE-related question here from a country club in KZN, where it appears that there may be this questioner's opinion being extreme mask and gloves response. Is this sufficient enough, as the health and safety officer are advising not to rely on these PPE as only measures, but still practice personal hygiene and social distancing? Any further advice?
I think that he gives good advice, and I think that it's important, yes, to do the risk assessment, but also training is critical. In a security staff where maybe the one security guard, or in any setting, even in cleaning, any kind of setting, where you're using you may be using gloves, but you're using the same gloves to continuously do things, touch other surfaces, touch somebody's bag, touch something else. We're actually promoting spread in those circumstances. So proper training needs to be advised. So if in that kind of scenario, maybe gloves is not the ideal, maybe if we can get our hands on hand sanitizers or hand washing between each task that needs to be done, that's maybe a more effective way of infection control. So we need to take a look at each setting, do the risk assessment, and then train our staff well in using whatever controls we put in place.
And so the next question is about alternative recipe for production of sanitizer. We've covered that question. We are going to test one particular recipe, and we would on our website definitely let you know what is the one that we find acceptable. Tanisha?
But they're referring to bleach and jig. Bleach and jig. Bleach is effective. The percentage that Monica presented, that is effective, and that can go ahead. The recipe we were talking about was the hand sanitizer gel.
Right.
Yeah.
So this would be for cleaning surface, Monica?
Yes. And just to be made the person just to know that they should be cautious. If that sanitizer is referring to hand sanitation, caution must be taken because it can be an irritation to the skin.
So
but for surface cleaning, that's okay.
So it's important to distinguish in our terminology, especially after this training. We're going to go back into our workplaces to guide our colleagues and management, etc., to make a clear distinction between surface cleaning and the recipe for hand sanitizer. Thank you, Anika. Since it's said that the coronaviruses are a family of viruses, how many of this will survive the approaching winter season?
I wish we knew that. Yeah.
So my sense is there will be the common flu that will still be coming around. That flu vaccine is what is recommended by the medical practitioners. But generally, the coronavirus, COVID-19, has caused us to up our game, for lack of a better word, to improve on general hygiene, personal hygiene, home hygiene, cleaning practices Anika shared with us, and particularly for our audience here, workplace hygiene. So I think social distancing, all the measures that we've spoken about. I'm not sure if the COVID-19 specific, where the risk assessment indicates high risk of exposure, then we need to take the additional measures as recommended by my colleagues. Is there anything else you want to add to that one?
No, I was just saying, let's check out.
Yes. So the number of members, okay, apologies. I just need to quickly scroll down myself. A pick-it-up question from Janet Macau. Is the government going to supply community with vaccine forward?
That we don't know.
We'd have to redirect that to the appropriate government. And that would, so if you're a state employee, a public servant, it would be important for you to, as we yesterday encouraged the dialogue between employees and employers and management, for you to have that very constructive and productive engagements. We cannot defeat COVID-19 in South Africa as a nation under the state of disaster declared, as well as in our workplaces if we're not going to engage in that concept, please direct that question there and explain that this is the COVID-19 virus that doesn't make a distinction between our status in the workplace. It will affect all human beings equally. So if the next question that we're looking at is people traveling on a bus or minibus, where they do not have the control of fellow people in the minibus, is using a mask at the time whilst in the bus or taxi the best prevention?
I think, as we have mentioned, that a mask is protecting others from you. So you have to know the purpose of using any kind of a PPE. I think with this corona situation, I happen to be really observant, because I also see taxis and even our vehicles, we're closing the windows. Then if it's possible, maybe we should have a mindset change and we start opening the windows while in buses, public transport, for example. Then maybe that can help.
I'm going to ask a layperson's question as if I'm a member of the public. If I'm in a taxi and I am not in the kind of 2-meter preferred sort of arrangement, for the time that I'm there and I hear somebody coughing seriously and I put a very clean serviette over my breathing zone for the time that I'm in the taxi, could that help? And then hand sanitizer, hand washing once I get out of the taxi.
I think that is a good hygiene etiquette to sneeze or you cough and you put something on you. But what I cannot guarantee is if you have someone sneeze, those droplets, will they really go through that tissue or whatever and get to your nose?
Well, I would probably discard of that as soon as I get out of the taxi,
yes,
safely in an actual bin and not on the seat corner.
yes.
Okay. So there's the question of how I differentiate between normal flu and COVID-19 symptoms. Is there a cardinal sign?
No, there isn't, unfortunately. And that's why, the flu vaccine is encouraged, because we won't know without testing whether it's influenza virus or whether it's the coronavirus. So, no.
Essentially, it's a lab test that confirms and distinguishes.
So to prevent unnecessary testing, because you're having the same symptoms, it could be flu, and then you're testing for COVID. Rather protect yourself by taking the flu vaccine.
We need to be proactive about this, including our range in the workplace. One person says that he or she is slightly confused. Why do you, like most responsible individuals, keep saying the coronavirus dies after some time if it's on the surface? Why can't you say it gets deactivated? It's terminology here. And clearly, if we're looking at the trend session, let's deal with the issue of what might be the correct and appropriate terminology as well. But it gets activated as long as the environment is conducive. Does the virus really die when it becomes active unless kept under careful control conditions? A technical question for NICD.
I think it's a living organism,
Biological matter.
Yeah, so right in the top. And so it does die.
So if you have the particles, the viral particles are within a droplet. And when that settles down, the droplet then dehydrates, and that allows the virus to die. And the time that takes differs depending on the environment, whether it's what the temperature is, what the surface is. So there's many factors in terms of how that virus is going to die or survive in the environment. And if you are applying cleaning agents, then we're talking about deactivating that virus.
The next question is about the flu vaccine. I know there's a bit of a shine on our board here, so people can't see well from the side. Should we be encouraging employers to offer the flu shots to all employees, where possible, where the employer is willing and can afford? And will this result in shortages for vulnerable groups as the flu season approaches?
It's a real issue. And as we said, there's a real issue. That there are shortages of flu vaccines. There are people that are more vulnerable, and who should get it and how should it be distributed is something that people need to tackle.
Okay, so Rizal was asking about a CCMA context, dispute resolution organization. We have staff members and the commissioners dealing with users, members of the public who come for cases at the CCMA. Would they also be classified as high risk exposure?
So,
they would definitely be an exposure group because they're dealing with the public that they don't know the infection of the person sitting in front of them coming for the advice. But I think high exposure groups are like healthcare workers who are dealing with someone we know is infected. So that kind of is, how we would say like an unknown person who could be, couldn't be, is not as high risk as someone who we know is going to actively look after and be in close proximity to someone who is known to be.
Also, my sense is that CCMA commissioners sit in boardrooms where they can have people 6 to 3 meters away on both sides of the parties. So the social distancing in those formal sessions where you do the conciliation, mediation, arbitrations can effectively be dealt with. So social distancing can still be put in place even in the CCMA context. Some workers will not be working directly with clients. Your admin workers, people who are completing forms where the distance is, I think, lower than 2 meters.
And one thing to do is perhaps start a screening process at the door, so that we limit individuals that's coming through that are symptomatic. So, having posters available and someone manning the door will help, because you're having large volumes of people that's going to be sitting in the waiting area, waiting to be attended. So that's something to consider.
Yeah. So a person tests positive for COVID-19 and symptoms to be treated, then tests negative. Can this person contact the device again? We've covered that.
Yes.
Yeah. For people testing positive, whether contracted in office or outside, can claims be registered with the compensation fund? I'm going to recommend to this participant to join us at 2 o'clock this afternoon. And all of this will be discussed by a legal expert as well as representation from the compensation fund and the Department of Employment and Labour. And I think an additional person from the South African Society of Occupational Medicine. I did post, and you can see it in the chat, the link for this afternoon session, and you are welcome to join us at 2 o'clock for that session, where there will be a panel of people addressing those questions of labour relations with COVID-19, including issues of leave, etc.
I'm sorry, just to add to that, it is within the legislation of the compensation, the COIDA legislation. If an OMP feels that, or if a medical practitioner feels that this is a work-related infection, it is the duty to report it to the compensation commissioner, and for them to then decide if the OMP should make a case for why they feel that it was work acquired, and this then should be submitted to the Department of Labour.
And therefore we recognize an occupational disease on the date of diagnosis, and the necessary compensation fund benefits in these different categories may be applicable. Please join us this afternoon at 2 p.m. Thanks for that, again. So, will COVID-19 I think this is the same question, right? Will COVID-19 regarded? I think it's the circumstances that are going to determine this, and I think join us this afternoon is the short version. We have 10 more minutes left of our session. I'm trying to get through as many possible questions that we can manage in the next 10 minutes. So from, there's the question with regard to transportation. There were these 2 technical, categories that were raised in this question. Do we transport samples as 3373 or 2814? We will certainly redirect you to the NICT and their particular hotline to deal with that. We're not in a position to give you an immediate answer on that now. Tanusha?
I think, Ashra, maybe, I think the hotline is also going to be inundated with calls. Perhaps we can get that document, that guidance document for sample collection and transport, and share it with the group.
Right. So Melanie, that's Melanie Davids. We will, if you have included your email address in our chat bubble, then we will definitely get it back to all of those that are on the list. Our next, Anika, you will assist us with that, right? To get that particular document?
Yes.
Thank you very much. From Esme, risk and consequence, I see that existing standard operating procedures need to be intensified to accommodate this high-risk assessment process, and so not necessarily reinventing the wheel. Comments on that statement?
You know, SOPs need to be in place, but oftentimes they are very specific to the company. And so the thought was to look at what is existing SOPs in place with regards to leave, with regards to cleaning procedures, with regards to how to do a risk assessment and who does it, and review those internally within the company.
Okay. The next question is for people who have self-quarantine or social distancing. Whilst there are many in the house, maybe 5 or 6 or more, would admission be the better method of protecting the whole household from contracting the virus?
You know, there's different forms of quarantine, you know. It can be done in the home or it can be done outside the home. But, you know, we have to look at our health system, you know, and possibly our health system is not equipped to do quarantine when you are asymptomatic. Remember, when you quarantine, you're not sick, and our health system needs to be left for you know, people who are actually sick and are going to burden it now with the people who get severely sick from COVID-19.
Right. So there's a follow-up point there by Joyce. Are retailers the ones at high risk?
I think it's very similar to the previous question, where you deal with the public. Where you deal with the public, you are at risk, but not necessarily high risk. Because the public, we're not sure who's infected and who isn't infected. So there is definitely a risk there. But where you know you are in close contact with an infected individual, and that is part of your job to be in close contact with that person, those people are high risk.
Right. And then can pets get COVID-19? If my beloved dog or cat is in my company when I'm COVID-19 positive?
We can come back onto that one.
Okay.
I haven't seen it.
We'll have to consult with those who specialize in the animal category. Okay. Our next question is, what about the health risks, healthcare risk waste for the private sector? Glenn, can you just shoot it slightly down? Thank you. What about the healthcare risk waste for the private sector, that is after the wearing of gloves and masks? What is supposed to happen with that waste? It can be discarded with normal waste, but should be disposed of in the red bags or containers as per the healthcare, I guess that's at risk waste regulations. Is there access to that for the public? Is the public informed on that? Disposal of contaminated materials and PPE.
I think it needs to be specific, you know, it needs medical waste needs to be put in the appropriate waste so that it doesn't further contaminate down the line, whoever's managing the waste. So those things need to be addressed. If in specific workplaces where they do have medical waste, this should be done in safe, you know, as per the.
And at home, I guess I would need to have a packet in my bin, and all my children and families' tissues that goes to that needs to be tied up immediately when it's, you know, before it gets taken out of the bin, and then disposed and not be kept around, nor for pets to get to be able to break open these sort of packets. Tanisha?
Yes, absolutely correct. I would suggest the same.
Okay, so the next one is COVID-19 covered under the COID Act. We've covered that, right? Essentially, if it's an occupational disease diagnosed by a qualified occupational medical practitioner under the South African compensation legislation, it will then be submitted, as explained earlier by our dear my colleagues here, to the Compensation Commissioner's office, where the Compensation Commission make an adjudication on the case. And then the compensation fund may need to provide benefits. From the Department of Correctional Services, how long does it take to infect another person? secondly, what is the risk of correctional officials and inmates who are from correctional facilities?
I think that, there's a mean time, an average time of, like they say, 5.2 days, but it kind of ranges, and that is why we have that isolation period of 14 days, to kind of, that is kind of the time that it incubates, and you should show symptoms if you are infected within that time. So it's roughly about 14 days, give or take. What is the risk?
I think also to add on that, we have developed a poster which is going to talk specifically to correctional services. And some of the recommendations we're saying that there must be processes in place, including screening inmates during intake, to make sure that if those who are showing symptoms, they should be isolated. And also there should be a process of educating officials to identify those who are already in once they start to show symptoms to be isolated. So those are some of the examples, but I mean, with the knowledge that officials got today, we believe that they can really adopt some of our recommendations.
Okay. So the next one is, what would you recommend be done to satisfy the monitoring and medical surveillance component of legislation with regards to COVID? We already discussed the PCR, and that's, I think, the lab test, am I correct? PCR for the legal that we're using here does not differentiate between viral and non-viral. Should employers do fever monitoring? Resetting a whole workforce for medical does not seem feasible, considering the limited testing capacity. What are your thoughts?
With regards to sort of medical surveillance, I think this needs to really be determined by our risk assessment. And I think, there's one guidance document that I've seen, and that's from the CDC, and it's specific to healthcare workers. And they are a very high risk group, and it talks about, it gives guidance to medical surveillance, particularly in this high risk group, and it categorizes the work, the healthcare workers exposed as high, medium, or low risk. So those who have been treating an infected patient without the recommended respiratory protection, and the patient that they were treating as a known COVID patient and wasn't wearing a mask, they treat differently. So they isolate those people they treat them as a high risk, they first categorize them as such, and then they isolate those people and do specific surveillance on those people, symptom monitoring, temperature checks. So those are specific high risk employees, and that's really a high risk. So we need to look at our employees and see whether or not they're high risk or not, and that must dictate the medical surveillance. It needs to be a thought-through process. People who are low risk, even people, healthcare workers that that have as much a risk as anybody else in terms of, just not really in a high case setting. It may not be required. So please just do that specific assessment for the workers to see who needs it and who doesn't, because you're right, we can't be wasting resources.
Thank you, Gail. And then a question.
I just want to say something on the PCR does not differentiate between viable and non-viable. That is, whether the virus is alive or whether the virus is dead. It detects the RNA of the virus. So I'm seeing the viral versus non-viral. It should be viable.
Okay, so Jian Swanepoel, with regard to your question, just a correction there on your use of terminology, not viral and versus non-viral, but viable versus non-viable for the PCR case. But we get your question. Thanks. The next question is COVID-19 classified as an HBA4 category. That means hazardous biological agent 4, and that would be described by the hazardous biological agents regulations.
Yeah, but we haven't got any pronouncement on what it's been classified under, whether it's a 3 or 4 yet.
Okay, we'll have to monitor progress on that particular question. So, yes, and then the next question is from the district municipality. How do we deal with employees, especially at ground level, who are going to use this period to be absent from work. And I guess this is the question of legitimate reasons to not be at work versus abuse of leave provisions under the certain circumstances. Maybe falsely present symptoms or give incorrect information so they can be excused in the workplace, that is self-quarantine as advised. So let's deal with that question of legitimate use of time off, and or do we recommend people to join us at 2 o'clock this afternoon, since we are practically out of time?
Yeah. Just to say that if someone is saying that I'm self-quarantined because I think I have symptoms, they need to contact NICD for contact tracing and for advice to be, because that's if they are symptomatic. If they are not symptomatic, they still need to inform. So there is a process, and that's going to get discussed later on. And so this needs to be managed through the HR process to control this abuse of leave.
Okay. And then the next question is, the organization has a biometric gate at all entrances. There are also automated sanitizers in place next to the gate. Is it advisable to deactivate the use of biometric systems during this period of outbreak? I know that universities like UJ, but I think UP has moved towards the deactivation of that.
Yeah, so if there is another method of access control, like the university, some of them have the cards that they can use as an alternate access control, that's great. If not, then is there the sanitizers available, the wipes available to disinfect or decontaminate the surfaces, or people before they touch and after they touch, they can hand sanitize. So that's something they have to look at, what controls they have in place.
And sorry, just to add to that, and where they put sanitizers and these things in place, people need to be trained,
Yeah.
you know, on that.
Okay, so I'm going to suggest that we just do one more question. It's already 3 minutes past 1. And this question is related, is it safe to do lung function testing? We covered this yesterday, the lung function testing.
The person may not
Yeah.
be on
Okay. So is it safe to do the lung function testing in an occupational setting? You have those who are not sure if they were in close contact with the person. All signs and symptoms are there. How do you trace?
It's a very common question and a very real problem that especially occupational health people are going to face. And I think we need to do a risk assessment of where, the environment, the setting that we're doing lung function testing. We need to see if there's ventilation there. We need to see the procedure in terms of is it disposable? Are we blowing out? What is that spirometry test? What method is being used? And we need to see, is there ways that we can mitigate the risk and weigh it up? If it still poses a risk, then we need to really look at reprioritizing our medical surveillance for when it's safe. So it's very specific to your situation, but it needs to be thoroughly reviewed.
Yes. I don't know if there's any final comments our panel wants to make. Monica? Yeah? Tanisha?
One last one.
Please.
I know that we spoke about leave and we're going to have a whole session on this a little bit later, but I think that we also need to work with our workers here. We need to foster the environment that looks for us isolating this disease and preventing spread, as opposed to looking for the offenders who are going to abuse the sick leave. So I think that, yes, we need to take that into account, but our approach needs to be we all need to work together, creating a safe place for people to report when they need to, so that we limit the spread of this disease.
And just to add to what Odette said, do remember that we have places where people gather for long times. Workplaces are one of those places, or places of worship and so on. Even if the number is below 99, we need to use these opportunities where we have contact with our employees as employers to ensure that we have a repository of the factual information available to them at the click of a finger, so that we can help inform our employees to then avoid all the fake news and then make proper and good decisions. And it's those places of the workplaces where we, in whatever public health sector and so on, can use as the opportunity with very clear dialogue, good cooperation. The COVID-19 is not going to make distinction if you're an employee or an employer, manager or a cleaner. It's going to affect us all equally, and therefore we have one clear solidarity platform in order to both be prepared in the workplace and ensure prevention at the workplace. At this point, I want to thank my panelists from the National Institute for Occupational Health, Dr. Tanusha Singh, the head of the Immunology and Microbiology section, as well as the chairperson of our COVID-19 outbreak response team here at the NIOH, Dr. Odette Volming from the Occupational Medicine section, as well as Ms. Jeanette Mangani, the head of our Occupational Hygiene section, and then Ms. Dikuledi Matuka, who's also from the Immunology and Microbiology section of NIOH. I thank you very much for your contributions. Yes.
I'm saying the questions which we didn't answer, we're going to do them offline and we're going to respond back.
Yes, we are continuously working on an FAQ, frequently asked questions document, and we will update that document with the additional questions we haven't covered in our session. We thank you very much for contributing your questions. We do all of your email addresses, and we will undertake under our own constrained resource scenario to get the information to you as soon as possible. We'll soon also be able to send you links to show you where you were able to find it on various websites, including our own. I want to say thank you very much on behalf of the NIOH, that is the National Institute for Occupational Health team here for today's session, our COVID-19 Train the Trainer session. At 2 o'clock in our chat room, you've seen the link, and please copy it, because once you log off, you can't access it there as well. There is our link for our session that deals with COVID-19 and labor relations. We bid you farewell and see you in the next edition of the NIOH's COVID-19 channel, which I just named. Thank you.
Thank you, Asha.